Well, I think as you can see, 1 minute of silence seems like 20 minutes. So we'll go ahead and get started. It is my extreme pleasure to introduce our guest speaker today for the webinar, Dr. Lisa Brener. I have known Dr. Brener coming up on 2 decades. And that just tells you how old I am. I knew her when she was a very, very young
An
woman, and she
infant.
still is a very young, beautiful woman. So,
Yes.
and and you know, in introducing Dr. Brenner, I think it's really important to appreciate that she is an expert, a recognized expert in so many areas, in suicide prevention and treatment, in traumatic brain injury prevention and treatment, in women's health, in military sexual trauma, in resilience, in military transition. Her skill set, there probably is not another person in America that I can think of that has the depth and expertise in so many different areas as Dr. Brenner. And so we're so lucky to have her with us today. You can see her talk is only going to touch on a few of those areas: traumatic brain injury, PTSD, and military sexual trauma. Dr. Brenner works for the Department of Veterans Affairs in America. She also has an academic appointment. I'm not going to go into all of that. You can, if you Googled her, her CV would come up and it'd blow you away. But I'm going to stop there. And Dr. Brenner, Lisa, if I left anything out that you want to
No,
highlight,
thank
but I'm
God.
going to
Let's
turn it
move
over to you
on.
now and go on silent. But
Thank
thank you
you.
so much for being here, and thank everyone for attending the webinar as well.
And thank you so much for the invitation. And Carl is too kind, of course. And I'm just so grateful to have, such long-term colleagues to kind of work on this stuff with and all be in this together. And Carl and I really got to know each other during the conflicts in Iraq and Afghanistan. And, I think what many of us are trying to do is bring lessons learned forward and try to bring those to you. And we are aware, and I'm acutely aware of how different some of the experiences that we dealt with in terms of our soldiers and military personnel in Iraq and Afghanistan are to what you all going through right now. But try to kind of pick some things to highlight that I hope will be helpful and useful. I tried to pick kind of top level topics around women's health. And I know that there's going to be additional lectures around women's health and ways of thinking about this. And I'm going to just start by saying there's just not as much out there about kind of the impact on women's health during conflicts and armed conflicts as that there's just not as much out there. And that is a huge problem. And it also just impacts how we think about things and what we can bring forward in terms of evidence-based steps. But what I did find, I'm bringing forward, and we can interpret it to the best of our knowledge. So really, just even very recently, you can see the UN in 2006 began to create an opinion and an opinion piece about kind of how war and armed conflict impacts different women and children differently than men. And I think this kind of acknowledgement and understanding that things may be different for women, both in terms of context and in terms of health, is super important. So you can see this statement here that violence experienced by women and girls during armed conflict, and the acknowledgement that it can range from physical to sexual to psychological, and that it can be perpetrated by both state and non-state actors, has a huge range of bad outcomes, ranging from murder, unlawful killings, torture, other inhumane and degrading treatment, punishments, rape. And I think although there can be sexual violence, certainly towards men during conflict, the understanding that the sexual violence and reproductive health is just different for women, and that is a unique factor that we need to start taking into account when we're thinking about the impact of war on women. So do want to highlight that idea of sexual violence, and that sexual violence actually has many, many purposes and can be used as a form of torture, to inflict injury, to extract information, to be degrading and intimidating, or destroy communities. And so certainly thinking about how sexual violence impacts women, specifically, both in terms of psychological health and physical health, is something we'll be touching on today. And then I think the thing that's very, very important also is that this was an article that I found that I thought was interesting, because it was written by folks in Northern Ireland during the times of Troubles. And I think it has huge implications for perhaps women who are in countries that are in conflict or at war, and that perhaps they're in the safer zones, but that even being in the safe zone, that there are ways that sexual violence, things like strategic rape, or the idea of harm, or the idea that other women in the country are being subjected to harm, really does impact women in the country on whole. And so I would suggest, and this is something that certainly needs to be studied, that being in a country where sexual violence is happening at all against women as part of the military conflict does impact the health of all of the women in that country, and does kind of linger as a threat to women on whole. And that we really need to kind of think about how that might be impacting women across the country in Ukraine, whether or not they're in safer zones or whether directly involved in military combat. In addition, people have begun to think about specifically gender-based violence and reproductive health. And I think what you're going to see today is what I'm going to try to weave together is context, the context that things are happening in, women's health, and then specific conditions of interest that frequently come up during war. I am going to end on some things that I think we can do right now in terms of hopefulness, and also talk about contextual things that societies and institutions do that aren't as good for women or humans, and that we can maybe think about. But I think this idea of war impacting things in a widespread manner, in terms of economy, infrastructure, well-being, and then how each of those then can impact women's health and reproductive health is very, very important. Certainly not all of these fit in every circumstance, but I think really thinking holistically about society contextually, and then thinking about health, and then thinking about reproduction is really important. And I'll show you an article in a moment from researchers in Ukraine that I think really gets at this, and folks there should be highly commended for thinking about this already, even in the midst of things. Okay, and so I kind of have highlighted this in last time I spoke too, that I really think about human beings' brain health, but to be honest, whole health in a much more holistic way. So whether I'm talking about traumatic brain injury, whether I'm talking about reproductive health, whether I'm talking about, to be honest, cardiac health, anything, I think about mental health and physical health as both having interplay between each other, and that they each impact each other. And if we can start to think about women's health more holistically, as I talk about each of these discrete areas, I think we're going to be better off. And I'll show you a paper that does just that. Okay, so the other thing that we have been thinking about for quite some time is this idea that, there really is an accumulation of stressors over time. And I am very aware that things in Ukraine, this is not the first challenging period in Ukraine, and that people have had experiences even before this that they are carrying forward with them. And I do think that we need to think about each of these health conditions in the context of individual accumulation of stressors over time. And this idea that you accumulate burden, or that you accumulate health conditions, and that those health conditions, whether they're physical or psychological, can be mutually exacerbating. And I think this is really, really important. And I know that when we were at the beginning of the conflicts in Iraq and Afghanistan, many of us saw individuals come back and they had one TBI, supposedly, while they were in conflict, and they were having a really, really hard time. And people were very focused on, well, if this person has had one brain injury, why are they not recovering? Why are they having such a hard time? Why aren't they returning to kind of baseline functioning like we expect? And what we began to uncover over time is, of course, this was not their first brain injury. They had sustained 5 brain injuries before they went to Iraq and Afghanistan. This was actually their 6th brain injury, and they were actually beginning to experience post-traumatic symptoms or acute stress disorder on top of it. And so that made the functional presentation make much more sense than thinking about recovering from one brain injury. So when we are thinking about patients that they're working with, they're going to present with their current chief complaint or their current stressor or their current exposure, whether that's physical or psychological. And how do we think about things being mutually exacerbating? What do I know about their history, their cognitive, physical, emotional, financial functioning previously, currently, that could result in increased disability? And I frequently think about the injury that or the exposure that pushes people over or pushes people off their trajectory. So you could perhaps sustain your trajectory in terms of life, keep achieving, keep doing well, keep functioning. And then I think everybody has an exposure load. And what is it? What injury, what event? And some exposure loads are obvious. If you get a moderate to severe TBI, most people's exposure loads are overloaded and they will have a huge decrease in functioning. But for each individual, in the context of their lives, this is different. And how do we understand this contextually and over time, taking a life course perspective for people? Okay. So in terms of TBI, I think folks are quite aware, but I just want to make sure we're talking about the same thing. We still do talk about mild, moderate, and severe TBI. TBI is just an injury event in which there is exposure to the brain of some sort that results in a loss of consciousness, alteration of consciousness, change of mental status. This can be really, really challenging because that change of mental status can be, I felt like my bell was rung to I was in a persistent vegetative state. All of that's still called TBI in our current nomenclature. We do know that TBIs seem to accumulate over time. So that, again, this idea of accumulation, that one TBI usually people can recover from, 2, 3, 4, 5, even 6 mild TBIs begins to be more problematic. There is some controversy right now about the idea of mild versus moderate and severe. And the reason for that is because mild and severe in this case pertains to the alteration of brain functioning at the time of injury. It doesn't pertain to the severity of symptoms after the injury. So people can have a mild TBI where they had a brief loss of consciousness, but they can have persistent headaches, dizziness, balance problems that go on for quite some time, particularly if they've had other previous exposures. The majority, and I want to say the vast majority of work that has been conducted regarding TBI has been among men. That's for a number of reasons. Primarily that men more frequently sustain brain injuries than women, but really, that's not totally true, and particularly in terms of sports-related injury. I really like this article, and I want to highlight because it does two things that I really like and I've already talked about today. One is it thinks about brain injury in the context of women and how that might be different than men. And then it also thinks about brain injury in the context of lifespan, right? And in getting ready for this talk, I was realizing that we kind of actually have come some way in learning more about pediatric brain injuries in girls. We're actually learning a little bit about adolescent brain injury in girls because of sports in the United States. And we know a little bit more about brain injury in older women because of falls. Falls in older women is a great source of brain injury. I should say also the majority of brain injuries that occur, like 80% are mild. And even in conflict zones, the majority of brain injuries that occur are mild. What we don't know very much about, and the research is scant, is that kind of period of time from like when you maybe stop playing sports in the United States competitively, when you finish high school, go to college, and you're aged and frail and potentially falling. We all know almost nothing about that period of time for women. And as is beautifully, I think, highlighted on this figure, is there is a huge amount that happens in terms of reproductive health during that period of time. And we have very little knowledge about the interaction between reproductive health, hormones, and functioning after brain injury. And so, I mean, this is an area that continues to be wide open, and we know very, very little. Interestingly, there has been some work about female hormones and being somewhat protective for brain injury to the degree that that did result in a number of studies looking at hormones as a treatment across men and women for brain injury. Unfortunately, all of those studies have been horribly disappointing. So it looks like if you take the hormones out of the women, they become less protective. And you know, it makes me think about kind of the context that hormones are only a piece of the whole contextual piece that's happening for women, or the hormones we've identified. Again, so really thinking about brain injury in the context of all of these different things, and the interaction between reproductive health, stage of reproductive health, and brain injury. In terms of outcomes and care, this was a study that was done fairly recently, which I thought was interesting because it also suggests that there are reasons, there are things, and we're not sure totally why of these things that do get in the way of care pathways and outcomes between women and men. So this was done in Europe. Obviously, this kind of work takes a very, very large database. And what you see here is up on table 2, up on the left, you see women and men with mild TBI and women and men with moderate to severe TBI. This is particularly looking at care and care pathways. And there are some significant differences, not so much for moderate to severe TBI, but for more mild TBI. So women and men have differences in terms of, are they discharged home? Are they admitted to the ICU? And are they, does it take longer for them to actually get some of the imaging and diagnostic procedures? And so just interesting that there are differences in these, and again, calling into question why would there be differences if you have like injuries, and what contextual factors potentially get in the way for women with milder injuries, perhaps getting the care or the diagnostic information they need as quickly as men. We do also know that there are differences in outcomes for men and women in terms of brain injury. And here again, you have mild TBI on the left, moderate to severe TBI on the right, men and women. And then if you see this figure 3 below, that is for mild TBI. Again, lots of difference here in terms of outcomes, whether people return to work, well, women less than men, whether they have symptoms, so post-concussive symptoms, headache, dizziness, balance problems, trouble with sleep, women significantly more than men, significantly more depression, significantly more anxiety and PTSD, and significant impairment in terms of health-related quality of life, differences between men and women in terms of outcomes. So same injury, different outcomes, and equally different for moderate to severe. So again, getting back to this idea that the brain in which the context of the individual in terms of reproductive health, sex organs, hormones are different, and having some different outcomes after brain injury, both mild and moderate and severe. This is the study that I was talking about that I think is just really admirable that this was done by colleagues, your colleagues in Ukraine, and I'm proud to call them colleagues. They looked at the impact of war in Ukraine on reproductive health, and in particular, they looked at the idea of post-concussive symptoms. So looking at something that we may not think of in terms of something that's happening in the brain in terms of concussion, and then how that impacted fertility and other reproductive health symptoms. They found that female soldiers with post-concussive symptoms were more likely to experience longer periods, have more painful menstruation, have heavier periods and more frequent, that they had more problems with infertility than those who suffered a concussion, and in particular with post-concussive symptoms versus those without, and that those who suffered a concussion had more challenges with endometrial structure. And so I think this is just a really interesting thing to think about. How do these things start to play together? And what do we need to think about women's bodies on whole and things that are happening in the brain? We often locate perhaps post-traumatic stress disorder or post-concussive symptoms from brain injury in the brain, how do we then begin to think more holistically about how the brain and things that happen in the brain and hormonal control impact things like reproductive health? There are some groups that are doing some great work in this area. This is a group of folks who are focused on specifically thinking about brain injury amongst women. This website, I just want to highlight for folks, they're really trying to be like a one-stop shop where people can go and learn about the latest advances in terms of brain injury among women. It's called Pink Concussions. They do have information about concussion is synonymous with mild TBI. They do have lots of good information on this website also about moderate and severe brain injury. And I know that when I was going to give this talk, this was one of the first places I went because I just wanted to see what they had up and what kind of advocacy work they're doing. And they also have lectures on there and other things if this is an area of interest for folks. So just wanted to highlight this as a resource for individuals as they move forward. Okay, so I'm going to switch gears for a minute, talk about PTSD, which I think an acute stress disorder, also located in the brain. So just as a reminder, I know folks know this, that acute stress disorder and PTSD, post-traumatic stress disorder, are related. The diagnosis of acute stress disorder is really from 3 days to 1 month following an event. So really the acute phase, you do need to meet 9 of 14 symptoms. The symptoms are very similar to those with PTSD in terms of intrusive thoughts, avoidance behaviors, negative mood, changes in arousal and reactivity, dissociative symptoms, and inability to return to normal. I do want to highlight that after you're exposed to a stressor, it is very normal to physiologically have some of these, and most people do. This is the way our bodies are built. And it is a protective thing, a protective mechanism. I know, I've been in car accidents where, the next day I'm a little bit like hyper vigilant when I'm driving, or I'm like a little bit avoidant of driving. That's not a disorder. That's just the way your brain works. So it really takes these occurring, a lot of them over time in a persistent way. Acute stress disorder does increase risk for post-traumatic stress disorder. And we do want to find ways to address acute stress disorder and acute stress symptoms so that we can prevent post-traumatic stress disorder. Unfortunately, not a ton of research has been done about how to prevent or how to keep acute stress from turning into post-traumatic stress. We do know that things like psychoeducation, normalizing symptoms, and helping people return to activities and create structure does seem to help people. I know that folks in other countries are also trying to really figure out how to implement more structured protocols around acute stress disorder, but we're not where we need to be for that for sure, and certainly not where we need to be in terms of thinking about efficacious treatments for men versus women, or are there things that work in a different way for women? The other thing I do want to highlight is that I think some of the basics are super important. And some of it's not fancy, like, can we help people get back to structure? Can we help people get back to eating regular meals? And can we help get people's sleep pattern back to somewhat normal and helping people sleep again? There's lots of data that show that if people are sleeping, their post-concussive symptoms will go down and their post-traumatic symptoms or acute stress symptoms will go down. So how do we help people sleep and sleep well? Again, post-traumatic stress disorder, I think folks are very familiar with this. There's 4 types of symptoms consistent with what I just highlighted below. I like this little infographic from the Cleveland Clinic. And as you can see, that really there are many, many permutations of post-traumatic stress disorder. And people can look quite different, have different permutations, but still have this. This would again occur after 3 months, persist, and impact functioning to meet criteria for post-traumatic stress disorder. Okay, so what do we know about differences between men and women in terms of PTSD? So among women veterans of the conflicts in Iraq and Afghanistan, data showed that almost 20% have been diagnosed with PTSD. I think differently than is there, hypothetically, women were not involved in combat in Iraq and Afghanistan, but because of the highly permeable front line and really dangerous situations appearing in many unexpected ways all over the countries. Many women, even though they weren't in combat positions, were certainly exposed to combat. And these are the numbers that we have and have right now. This is also interesting. This was a more recent publication that just came out this year. This is looking at sex differences in screening positive for post-traumatic stress disorder after combat injury. So in particular, these were women that were injured in combat. And you can see that men were about 40% of men who were injured, or 41% of men who were injured in combat screened positive for PTSD, and about 48% of women. So not hugely different, but different, and women a bit more at risk in terms of this. One thing I also just want to highlight here that I think is helpful is they're also, although they didn't split it out necessarily by gender here completely, they are also very interested in things that we've also been talking about, like concussion, previous psychiatric history. What are the other things that may impact contextually to increase these rates or decrease these rates? I'm only presenting this because some other groups I've been talking about recently haven't been using measurement-based care. And I would, if I could, I think it's really important to know that there are really good tools that could be translated that can help triage in terms of post-traumatic symptoms. This is the post-traumatic checklist. It's available online for free. I don't know if there's a Ukrainian version. Actually, I'm really curious if there is, if someone could tell us in the chat or tell us when we have questions. But I think really using these measures to help triage and track symptoms is super important, and to help you all know how to prioritize. I'm guessing that the mental health system is, that capacity is, limited based upon need, and that the need is huge. And so if you are using measures to help yourselves and help patients think about how acute their symptoms are, do they need evidence-based treatments for PTSD, or do they need more structure and are in a more acute stress stage? I want to acknowledge these folks, Lindsay Monteith and Ryan Holiday, my great colleagues in the Aspire Lab. They have done some really beautiful work in terms of understanding military sexual trauma, how sexual trauma that happens during conflicts and service can impact women's lives, and some really beautiful work about institutional betrayal that I'm going to talk about. So I just want to highlight them. And if you're, want to learn more about some of this work, please look them up. They're just amazing human beings and amazing colleagues and amazing scientists. So in the United States, we do have quite a large problem with military sexual trauma, which is sexual trauma which has resulted from physical assault of a sexual nature, battery of a sexual nature, or sexual harassment, which occurred to the individual while they were in the military. And also this idea of sexual harassment, unsolicited verbal or physical contact of a sexual nature, which is threatening in character. MST prevalence is quite high in the military, and although both genders can experience it, it's particularly higher amongst women. Of the 5.3 million women veterans screened, of the 5.3 million veterans screened by the Veterans Health Administration, about 35% of females and about 2.2% of males screened positive for military sexual trauma. So, and again, you can see these equally high numbers across the board that are pretty consistent. A third to even more than a third of individuals, women who served in the military, were screening positive for a history of military sexual trauma. And Lindsay and Ryan, one of the reasons I really love their work is that they do quite a bit of qualitative work trying to really get inside the experiences of women. And this is some of the work they did in terms of kind of what did women say about this sexual harassment or military sexual trauma. They talked about it being expected, constant, and normalized, that it was silencing and disempowering, that it changed their attitude towards the military and military service. So in terms of losing faith, losing relational trust, so that not being able to trust people in the chain of command as much anymore, and not being able to kind of trust the people that they're serving with. Internalizing messages conveyed about military sexual trauma, so that somehow feeling responsible for what had happened, trying to actually avoid it, just putting it out of their head, putting their heads in the sand and pretending like it didn't happen. And then this idea that, you know, perhaps there'll be some way to heal through validation and justice. And how do we find ways to help women and men heal from military sexual trauma? So often people think of military sexual trauma only impacting mental health, like the very early slide that I showed you with reproductive health. MST does seem to impact many domains across the board. Again, further evidence for this idea of whole people and how traumatic stressors impact all of us in many different ways. So here in terms of mental health, physical health, perceptions of others and self, housing, employment, and interpersonal functioning. And here again, this idea that military sexual trauma is frequently discussed in the context of mental health and in particularly PTSD. And whereas that is true that military sexual trauma does often kind of co-occur with PTSD, the mental health sequelae are actually much broader. And MST is also associated with things like depression, anxiety, phobias, and other psychiatric conditions. Here you've got this just shows it for men and for women, that really this idea of mood, trauma, anxiety, eating disorders, substance use disorders, and personality disorders, all associated with military sexual trauma. So trying to kind of think more broadly when folks come in, and perhaps if they have some of these conditions, wanting to know a little bit more about their history that happened before this, if they have an alcohol or substance use problem, questioning about their history and looking at whether this is a potential driver of some of their mental health symptoms. And interestingly, military sexual trauma is also associated with COPD, so pulmonary disease, liver disease, renal disease, diabetes, and dementia, and then, of course, sexually transmitted infections and sexual functioning. In the United States, we're really quite interested in kind of contextual social determinants of health, so things that also could be related to MST. So women who screened positive for military sexual trauma, reported more psychosocial difficulties before the trauma and after the trauma, higher rates of homelessness amongst women who had a history of military sexual trauma or screened positive, and higher justice involvement. So more interaction with the the justice system, jails, prisons, and other police-related activity. So again, really these things traveling together in a way that creates huge challenges, I think, for mental health professionals, and requires us to look beyond just this diagnosis or this life event to look at the context in which this event's occurring. And finally, suicidal thoughts and behaviors certainly associated with military sexual trauma. And, you know, across the board, what folks have found is that folks have increased ideation, increased attempts, and increased death by suicide amongst those who have a history of military sexual trauma. Okay, so I want to take a step to the side for a second and talk about something that I think is really important and I think is really relevant to our time and talk here today. And one of the reasons I'm so thrilled to be with you today is that I think historically we have not spoken enough about some of these things. We have not spoken enough about kind of the impact of war on women, and in particular related to women and sex and reproductive health. And what we have found is that there is a really important role for institutions in terms of recovery. And so there's this concept of institutional betrayal. I'm not sure if folks have heard of this term before. I had not heard of it until I heard of it in this work, but I think it's a very useful contextual concept. And the idea is that when institutions fail to act in a way that prevent harm, or create environments that lead to harm, or respond in ways that exacerbate harm, individuals can feel betrayed by the institutions. And that like I said, I think even by talking about this today, we are doing something different. And that it is really, I think, relevant. And I know that we talked about this idea of institutional betrayal quite a bit during COVID in the United States, particularly during early days of COVID, when providers, healthcare providers, felt like they could not get the equipment that they needed to be able to take care of patients. They couldn't get protective equipment, and that the hospitals just didn't have the capacity. And what resulted is the sense of institutional betrayal by healthcare providers around the hospital system. So in terms of women's health, women's sexual health, are there things that institutions do to either to facilitate institutional betrayal or facilitate institutional support? So a potential explanation for some of MST being more severe than sexual violence in other life periods is perhaps because of the role of the institution. So this idea that military sexual trauma that happens in the context of an institution or a setting where you're supposed to be being part of a community, the military, and being taken care of by that community has even more negative outcomes. This may be particularly relevant because MST survivors commonly report experiences that can be construed as institutional betrayal, such as retaliation, blame, ostracization, and careers ending prematurely if the trauma did occur in the military. There are questionnaires that can be used, which I think are quite interesting, to look at whether specific institutions are responding well to stressors. This is called the Institutional Betrayal Questionnaire 2. And you can see here the section that I've highlighted will ask you to think about the larger military institution to which you belong and have belonged, which may or may not call to mind specific individuals. This has been altered a bit to be used for military settings. So here in thinking about military sexual trauma, what role did a military institution play? And you can see here not taking proactive steps to help prevent this kind of experience, making it difficult to report this kind of experience, covering up the experience, really getting away from the person, but getting to the institution and the role of the institution. Research with this work did suggest that female MST survivors identified 3 specific factors that warranted additional research. That's the environment. Are there things in the environment or the context that did lead to MST? How the institutional response to the MST happened, what happened when the institution found out there was MST, and what happened in terms of belonging. Did individuals still feel like they could be a part of the institution and find a way to reconnect the institution after the MST occurred? And I think those are all really important things to think about following some of these betrayals. So this was a small pilot study that Lindsay and her team did, where they looked at MST survivors, and those they nearly endorsed every kind of institutional betrayal you can see across the board. And to me, this just suggests that these are things that we should be asking about contextually, and then figuring out ways to address these and create different environments. Also, interestingly, institutional betrayal has not only been shown to be associated with MST, but also associated with depressive symptoms, further PTSD symptoms, and these are independent associations, and suicidal ideation during military service and afterwards. So really this idea of what can we do right now in real time as things are unfolding to prevent and address people's perception of institutional betrayals, and also how institutions are handling things that maybe historically they've been less willing to discuss or are harder to talk about. Okay. So one thing I also want to highlight is that military survivors, specifically military sexual trauma survivors, specifically discussed losing trust in military institutions as a result of military sexual trauma and institutional betrayal, which I've said. However, that also impacted them getting care in the future. And I think this is super important. In the United States, for veterans, we have the Department of Defense, where people serve in the military, and then we have the Veterans Health Administration, I think those things are often linked, even though they're different institutions. And what we are finding in some of this work is that women who had this institutional betrayal in one setting made them feel unsafe or unsure about all settings, all healthcare systems, and in particular the VA healthcare system, as a place that they could get care. And so it seemed to delay the care that they were going to get. And this idea that this happened to me through one part of a government or one government, and that distrust of governmental organizations on whole may impact people getting the care they need, both physical and psychological care. So you can see some of these quotes. I was afraid to come in for any kind of mental health care. I figured, well, the VA is the civilian branch of the military. So you know what happened then before is going to happen here too. Another person said, I lumped the VA and the military all into one system. It's one giant system, and I'm kind of leery about some forms of VA care. So I am not as smart as I should be about kind of institutions and how they are connected in Ukraine, but are there ways in which the military and healthcare systems are connected, even in people's minds, in a way that could make people nervous about getting care in the system, even if they are not connected to the military. And this also this idea of context. So Lindsay and Ryan again have really challenged us to think about what are people's pre-military experiences, what happened in the military or during the periods of conflict, how did that impact trust and safety beliefs, how does that impact disclosure and willingness to use military sexual trauma related care, particularly from institutions, but I would expand this. I would say any kind of care. And then how do we approach women and women's issues, whether that's MST related or pain related, right? If we are discounting women's pain, if we are discounting women's symptoms, if we are not providing women with the same health care, how are women's experiences being discounted so that they are overall less trusting of healthcare systems to take care of them? And how does this happen in big ways? Like in terms of just in general, us not taking women's symptoms seriously or not doing research on women's symptoms, which would be a manifestation of us just not taking women's health seriously enough on whole, to individual experiences where somebody comes to a medical provider, is talking about symptoms, and people do not take those symptoms as seriously as they should, and do not actually intervene in a way that makes sense. This idea that what happened before the military or before military conflicts impacts, so childhood adversity could impact an individual's view of the world. And so if you had, or a patient had experiences where they had childhood sexual trauma or any other kind of childhood trauma, how might that impact their perception of trauma that happens in the military, whether that's MST or not, and how might that impact them going forward? Also, in the United States, frequently, there was kind of a long time in which there was this like statement, boys will be boys. This is just what happens. Harassment is normal. And it's just kind of a normal part of boys being boys. If people grew up with those beliefs, how might that impact their sense of what happens to them in the military or during military conflicts, and how might it impact them getting care in the future? Again, if the system does not prevent MST from occurring, such as sexual harassment by a fellow officer or sexual assault by a commanding officer, how will that impact care over time? Following MST, if folks get the message that they will get in trouble, if their behavior, let's say drinking behavior, isn't associated with their trauma, and that they are shamed or they are afraid of, or they are presented with the idea that them coming forward with their truth might ruin somebody else's career, so that they should just let things go, also highly problematic. And then this idea of perceived lack of support from non-military entities or healthcare professionals, and us as healthcare professionals and mental health professionals not asking the right questions, not asking about reproductive health, not asking about these things that maybe we are only now becoming more and more used to asking about and talking about, how does that further senses of institutional betrayal and lack of support? And I think just to end on a helpful note, I think there are things that we can do that have institutional courage. And again, like I highlighted today, I think us talking about this today on this call is institutional courage. It's shedding light and bringing light to this idea that women's experiences are different, whether that's through brain injury, post-traumatic stress, fertility, reproductive health, or military sexual trauma. And how do we bring ideas of institutional courage to women's health during times of conflict? So, for example, research suggests that women with MST survivors can be validated, supported, and empowered, and that these experiences do facilitate recovery. So this idea of being heard and believed. And I think this does even relate to things like post-concussive symptoms. If women are having, we know women have headaches for longer, we know women have more headaches, that those headaches are taken seriously, that women are believed about their symptoms, whether they're related to TBI or military sexual trauma or PTSD, and that we intervene and provide support, that we will have institutional courage and likely facilitate women getting more sooner care to facilitate better long-term outcomes. So what is institutional courage? It's an institution's commitment to seek the truth, engage in moral action despite unpleasantness, risk, and short-term cost. A pledge to protect and care for those who depend on the institution by knowing as much as there is to know about healthcare for women, about knowing the special kinds of needs that women have, a place that transforms institutions to being more accountable and equitable, healthy places for everyone, and in particular about women's health and mental health, and really that there's institutional accountability and transparency about women's health. And here are some steps that I think that we can all be working on, both individually and institutionally, that we are complying with laws and go beyond compliance to ensure that people are cared for and healthy. We are educating ourselves, which we're doing right now. We're going to take this forward into our practice, so we're going to respond. We are going to ensure that we bear witness and hold ourselves and others accountable for the trauma that occurs to women, both physical and psychological, and really conduct ourselves in ways that we get the information that we need in terms of the recent conflicts there, the continuing repercussions for the conflicts here, and with other partners around the world, so that we can commit to just doing a better job to taking care of women over time. And here are just some examples, and particularly related to MST, that folks have used to let women know that they're not alone. And I think, creating institutional courage by programming, by public service messaging, by acknowledging differences, and really holding ourselves accountable individually and institutionally to make sure we are taking care of women and studying women in the best way that we can. And I think that's what I have for you today, and have some time for questions. Just really thank everybody for attending, and I hope this was close enough to on track for what was hoped for. I'm really open to folks asking questions if there's help with the interpretation too.
Please, if folks have questions, jump in.
Yeah. But folks, I wonder if this seems relevant. Does it seem on track, or just in terms of your experiences right now? Happy for comments.
Hi, hello. I would like to say something. My name is Tetyana Sirenko. I'm a Ukrainian psychotherapist, and today I'm the Deputy Director of Mental Health and Rehabilitation Center for Veterans. We work a lot with the members of the military, men and women. Over the time of the full-scale war, we have covered almost 10,000 patients. And I would like to say thank you to you for the information that you share. I actually learned very many interesting things about the research that you quoted and about the consequences of the TBI and their impact on the reproductive health. I appreciate learning about the new sources I could read to get more information. I would also like to give you some feedback because we do have very many excellent things established in Ukraine. They function quite well. Can you hear the interpreter? Excuse me. So I took notes when I was listening to you. First of all, I need to say that in Ukraine, we have the equal and full participation of women in the combat. There are many female combatants in Ukraine, and basically most of the combatants they experience blast traumas and they experience the consequences. The psychologists and the experts say today that we have the epidemics of the light TBI. That is why we do appreciate the best practices from all over the world, but we also have many of the lessons learned. Yes, indeed, Ukrainian women are affected, not only the military personnel, but also civilian women, because even civilian women, they are affected, women and men, they are affected by the TBI because of the blast trauma and concussions. And also taking into account the intensity of the hostilities, we receive patients with many comorbidities. We face the huge challenges with a long list of various comorbidities. Can you hear the interpreter? 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 Can you hear the interpreter?
Lisa, could you hear the interpreter?
Can you hear the interpreter now? I can give you a gist. I can give you a gist of what has been said right now, but I will ask the person to wait a second. Can you hear the interpreter? Carl, Carl,
I
can you hear the
the
interpreter?
interpreter fine.
So the lady's name is Tetyana Sirenko, and she is, yes, she is the deputy director of the Mental Health Center and the Center for the Rehabilitation of the Veterans. And they receive over the 2.5 years of the full-scale war. So she said she is a deputy director of the Mental Health Center and the Rehabilitation of Veterans, also men and women. Over the 2.5 years of the full-scale war, they have already treated about 10,000 patients. And she's trying to say that especially women veterans and women combatants who come to their center, they have many comorbidities. And thank you for the lecture, because it was a revelation and very many insight that I received about the reproductive health and especially about the impact of the light TBI on the reproductive health, because we are actually receiving not only the military personnel, but in Ukraine currently the situation is that there are many civilian women and men who are affected, who have the blast traumas and also post-concussion symptoms with many comorbidities in particular. And now she can continue and I will be interpreting. Please stay in this channel.
Thank you. Thank you for bearing with me. Just in response to her question too, and that was, I wanted to show that amazing article from Ukraine, but there have been other studies that have shown that traumatic brain injury, history of traumatic brain injury, even long post, can impact fertility. So this is something that we know. We also know that traumatic brain injury and blast exposure can impact a number of different health things long term, including, of course, something that seems like increased risk for neurodegenerative disease, but it also seems to increase risk for metabolic conditions and inflammatory conditions. So I think the cascade of things that can occur after a brain injury really our whole body, and we need to be thinking about that. We're just not as smart as we should be. We're trying to get smarter faster, but we're just not getting smart fast enough. But I'm so grateful all the work you're doing, and that I'm glad that it seems like what I said is consistent with what you're seeing, and hope we can continue to figure out better ways for folks.
Yes, indeed. Thank you. I also wanted to add about the military sexual trauma. From what has not been mentioned by you, I need to highlight some important things that today in the hostility areas and also in the occupied territories of Ukraine, there is sexual exploitation is the widespread instrument of war. We already can even speak of the mass character of this phenomena. Unfortunately, we already face the complicated consequences in the deoccupied territories, and we expect even more complicated consequences in the coming years. This is about the children who were born post-rape, and also this distant consequences and long-term consequences of traumas. Another focus shall be made on the sexually related torture when people stay in captivity by against the military and also against the civilians who were abducted. Very often it's about the injuries to the sex organs and also impact on torture on the reproductive system. They use electricity shock for torture for genitalia. One of the tools against Ukrainian women in captivity is the medications that are used to affect the hormones of women. We only started exploring into this matter. It's very difficult to get the evidence because women stay in captivity for many months, and when they get back from captivity, it's very difficult to detect the impact of the medications that they were administered to them. But we already have the facts, and we already have the research, and it's in the process. I'm sure we are going to learn many more new facts, especially about the long-term consequences. But I find it very important to voice this out and to speak out, because our colleagues from the US are listening to us now, and this topic has not been mentioned frequently.
I'm so grateful that
well,
you're bringing
that's
it up.
everything I wanted.
Yeah, no, I'm very, very grateful you're bringing it up. I want to say that, well, I'm going to volunteer, Carl, because I feel like I can, but I mean, anything that we can do to help with thinking about ways to research, to document, and to make sure that we are being courageous in our discussions and courageous in trying to find solutions, and bringing this to the fore as we would bring anything. Talk about brain injury. Let's talk about sexual trauma. They need to be talked about without stigma and as true, war-related injuries that we need to learn more about. So I am here standing by with you in every way, and so grateful for your courage in bringing it up today. Thank you.
Another brave feedback from me, taking into account my 10 years of experience of working with the military staff. I think I have the right to do this. I would like to say that we are very well aware of the topic of PTSD. Probably we should not spend time explaining diagnostics criteria to us. We are very well aware of the topic. We have been working with this for a decade. And I am taking courage to talk about it right now because I can see our colleagues who are listening. They are my colleagues. They have been working for decades on this. Probably we should not be spending time on this.
Great. No, I think that's great feedback. So I think I will have the folks that are in charge of this that are higher pay grade than myself. Sounds like focusing on some of these other topics will be more important. But I'll leave that to Caro and James.
Jim, did you have any more
Thank you.
questions or comments from the participants? Reactions, shared experiences? We would love to hear about the challenges that you're seeing in these areas or other areas. I saw a hand go up earlier. Did we capture that hand that went up earlier?
I'm going to have to go in a second. So I'm going to say goodbye and say I appreciate all the feedback and want to be helpful and always want to be more helpful. So just grateful to be able to be a part of this and sending you all so much love and so much care and thinking about you all the time here.
Thank
So-
you, Lisa, and we will stay in touch.
Thank
Yes,
you.
thank you so much. Thank you so much. Are there any more feedback or reactions from those who are still on?
One of the things that comes to mind, and this may be for the future, is thinking about the long-term consequences of all of this. And what does it mean in terms of addressing those consequences? And this war has now gone on for a very long time, and there's going to be, a long-term set of consequences that our Ukrainian colleagues will have to deal with, especially in their communities. And so thinking about that may be something for a future topic.
Agreed, Jim. Agreed. Okay, well, let's not drag this out any more than we do. Thank you, everyone. Jim, when is our next webinar, the date?
That will be the end of August. I'll give you the calendar date in a second when I
The
can get my.
is it the
phone.
23rd?
It would be the last Friday in August.
Oh, that's the 30th. So our next webinar will be the 30th of August.
Yes.
So please make a note of it. I made a note of it myself because I had the wrong date down. But thank you all so much. And if you have any topics that you really feel passionate about that you want us to try to address, please just send them to Oksana Bayer or Ole and we'll get those. So thank you all very much.